Hi, I'm Dr. Tom Cheetham, a family physician, and we want to bring you a series of short training episodes to help improve care of people with intellectual and developmental disabilities. This particular first in the series, really, that we're going to term Clinical Pearls, really is a list of things to remember, especially with adults with intellectual and developmental disabilities. I thought that had a kind of catchy title, but really a more accurate title would be this one, and it's all the mistakes I've made over some 3 decades of practice with providing primary care to adults with intellectual and developmental disabilities. And hopefully you can learn from this, and so you don't have to make some of the same mistakes. An alternative title would be, this is the Cliff Notes version of intellectual and developmental disability medicine. So, first rule, blame the drugs. A person often may not tell you when they have significant side effects. The person on an antipsychotic drug, for example, who has mild akathisia, that motor restlessness, could be misinterpreted, and instead of decreasing or eliminating that drug, the approach might be to increase the drug and in fact make the side effect worse. So people won't complain. I assume everybody's constipated until I prove otherwise. It is that common, and I'm ashamed to admit that I've had patients die from bowel obstruction, from constipation, so quickly I haven't been able to recognize it and intervene that quickly. Illness can present atypically and late with people with intellectual and developmental disabilities. So if you're not thinking about it, it can be a huge problem. The other thing I start by assuming the person has, because of the increased prevalence, is reflux. And again, people may have a limited way of communicating their pain and discomfort, and so it may come out as behavior, which is very easily misinterpreted as difficult behavior or even some kind of psychiatric sign. Seizures. Epilepsy is much more common. In the general population, epilepsy occurs about 1 in 100 people. But if you have an intellectual disability, at the mild end of the continuum, it's about 1 in 5 people. But as you move along to more severe and at the profound level of intellectual disability, the prevalence approaches 1 in 2. Aspiration is also increased, and it's not as difficult to tell when the person's coughing and choking when they're eating or drinking, but the person who aspirates silently may just have recurrent pneumonia. So that needs to be high on your differential list for all adults with intellectual and developmental disabilities. The etiology, if it's known, can be very helpful. And again, in the additional series that will follow, will highlight that further. But behavioral phenotypes can be a big help to you. Knowing the person has Down syndrome, as an example, suggests hypothyroidism, possibly significant depression, obstructive sleep apnea, and a number of things. Before you ever see that person, just knowing the etiology of their intellectual disability. And similarly, the level of their adaptive functioning can imply a lot of things. Another key element is the person different? You know, you take a history, you do an examination and develop a differential diagnosis. There have been some complex people where I've taken a history, done an examination, which may or may not be limited, and I'm still there scratching my head, even trying to figure out which body system am I thinking about. I mean, that's very unlike people without disabilities. And not everybody's this complex. But if I can help you approach people with the most complex challenges, then other patients you will look after will be easier. And so it's that element we learn in pediatrics that, you know, a parent says there's something wrong, we really have to take that seriously. but it may be so non-specific in adults with intellectual disabilities. The only history may be that the person's different. And on the website where these materials will remain is a case where that was the only complaint, and that frontline staff person was so persistent, she literally saved that person's life. Pain. Pain's a very important issue, and we tend to expect pain behavior as we would from any person, and that may not be the case. Sadly, often I hear the person with the intellectual disability doesn't experience pain, and that's patently false. They just don't show the same behavior and way of communicating pain that we might. So again, if you don't think about it, you'll miss it. Sleeping is important. Eating, thinking about dental issues, vision, hearing, all those things. If I had only one question, this is an unusual example to illustrate perhaps, but if I had only one question I could ask on a functional inquiry to try to decide if something's wrong, I'd ask, how's the person eating? Assuming they don't have tube feedings. And then lastly on this checklist is there a psychiatric disorder? We need to think about that a little bit more, and remember that anxiety is a recognized component of a number of syndromes, as are mood disorders, and we need to think of those before we think about schizophrenia and other psychotic disorders. Unfortunately, though, people present as if they're having more psychotic type behavior, and it's easy to misdiagnose that. This usually gives my psychiatric colleagues a little pause, but we know in primary care we don't always have access to the supports we need or as quickly as we need them. And so once you've ruled out physical health issues, if you're going to do an empirical trial of medication, it makes more sense to try something that's anxiolytic first. I've had good success with beta blockers in patients. And again, treating mood disorders and the anxiety before looking at an antipsychotic drug. Each one of the topics I've covered here will have additional material, again, in short segments that you can peruse and view when you're able to fit that in. And we welcome suggestions of other topics that might be helpful for people to have short presentations about. Thank you very much.